Imagine going through, the most intense physical trauma of your entire life, just childbirth.
Right. It's massive.
And then finding out that every time you laugh or cough or jump on a trampoline for the next decade, your own body might betray you. I mean, for 50% of women, postpartum bladder leaks are this silent, really embarrassing reality.
Yeah. And for decades, the medical advice has just basically been, do some Kegels, maybe lose some weight, and, just live with it.
Exactly. Just live with it. But what if the fix wasn't about just squeezing your muscles harder? What if it was about actually regrowing the very tissue that broke during delivery?
See, that completely shifts the whole paradigm of postpartum care
Yeah.
because we're moving away from just telling women to manage a symptom, right? And we're stepping into the realm of actual physical structural regeneration.
And that is exactly our mission for today's deep dive. We are tackling a super specific question, but one that's deeply relevant to millions of mothers. Like, can a regenerative treatment known as the O-shot actually reduce bladder leaks after childbirth?
It's such an important question to answer.
It really is. So if you are listening right now, whether you're a mother dealing with this daily frustration or maybe a partner trying to understand the physical toll of childbirth, or even if you're just someone fascinated by cutting-edge medical science, we are unpacking the biology and the real-world results today.
And we've got a really robust stack of sources for this, too.
Oh, absolutely. We're looking at peer-reviewed clinical trials, including this major prospective study published in MDPI. Plus, we've got urogynecology guidelines and actual hard data from medical clinics.
Yeah, and that clinical data reveals a problem that is it's incredibly widespread, but it's rarely discussed openly, mostly because of the heavy stigma attached to incontinence.
Right. Okay, so let's unpack this, because before we get into the whole space-age regenerative medicine part, we need to understand the physical reality of the leak itself. We're talking about stress urinary incontinence, or SUI. Just how common is this, really?
The scale is honestly staggering. I mean, studies show stress urinary incontinence affects up to 50% of women in the UK alone.
Wait, 50%, half.
Up to half, yeah. And for a massive portion of those women, the issue begins right after childbirth. And I should clarify, it's really important to differentiate SUI from other types of leaks.
Okay, how so?
Well, this isn't an urge issue where you suddenly feel like you have to sprint to the bathroom. SUI is a mechanical failure under pressure.
Half of all women experiencing a mechanical failure. That's just astronomical for something that nobody talks about.
It is. But to understand why those numbers are so high, you just have to look at what the body endures, During pregnancy, the sheer weight of the expanding uterus puts this enormous prolonged load on the pelvic floor.
Right, for months.
Exactly. And then comes the actual delivery. A baby passing through the birth canal severely stretches and traumatizes the pelvic floor muscles, the connective tissues, the mucosal linings, all of it.
Yeah, I was reading in the urogynecology guidelines we have, and the method of delivery plays a huge role. Like, women who deliver naturally have a 50% greater chance of developing postpartum SUI compared to those who have C-sections.
Which makes sense mechanically.
Right. And high BMI is another major risk factor because it's just adding even more downward pressure on those already weakened structures over time.
Precisely.
So you have a woman who just went through this massive trauma. She's dealing with a newborn, and now she's leaking urine every time she sneezes. And the traditional toolkit seems so painfully basic, like lose weight, cut out coffee because it irritates the bladder, and do Kegels.
Yeah. Pelvic floor muscle training. That's the standard first-line defense.
Right.
Because Kegels are designed to strengthen the pelvic floor muscles, so you get more control over the urinary sphincter.
But, and this is my big pushback here, if childbirth causes actual severe physical trauma, like literally stretching and tearing ligaments and tissues, why is the medical default just telling women to squeeze their muscles harder?
It's a fair question.
I mean, isn't that like trying to fix a leaky pipe by just painting over it? Like, if you tear a ligament in your knee, a doctor doesn't just say, hey, flex your calf muscle more.
That analogy perfectly highlights the limitation of the traditional approach. I mean, muscle training is vital for pelvic health, absolutely. But it completely misses the damaged connective tissue.
Because it's just targeting muscle.
Right. The root cause of the leak when a woman laughs or sneezes isn't always just a weak muscle. Usually it's a lack of urethral support. The fascial tissue, which is the connective tissue that acts like a supportive hammock for the bladder and urethra, it's been overstretched.
See, here is the aha moment for me from the research. You can work out a muscle to make it bigger and stronger, sure. But fascia, the connective tissue hammock, isn't a muscle.
No, it's not.
Doesn't have contractile fibers. It's more like a rubber band. So once it's been stretched way past its limit and it loses its snap, no amount of surrounding muscle flexing is going to magically restore the rubber band itself.
That is exactly the core physiological issue. You could have the strongest pelvic floor muscles in the world, but if that connective tissue hammock is sagging, the urethra simply won't stay securely closed when that intra-abdominal pressure spikes, during a sneeze or a jump.
Because the underlying structural hammock is still just broken.
Exactly.
So medical science started looking for ways to actually rebuild that rubber band, to fix the hammock itself. And that search led to a solution found not in like a daily pill or some major surgery, but literally in the patient's own veins.
Which brings us to platelet-rich plasma, or PRP. Now, PRP has been a staple in regenerative medicine for years. Orthopedic surgeons use it all the time to heal injured tendons, and dermatologists use it for severe tissue repair.
Right, like the vampire facials.
Yes, exactly. And now it's being applied to urogynecology under a very specific protocol.
Right, and the sources refer to this protocol as the O shot, which stands for orgasm shot, which, I mean, it's a very catchy marketing game.
It definitely gets your attention.
It does. But underneath that branding, we're talking about a serious medical procedure here. Let's walk through how we actually get this regenerative serum. Because it starts with a standard blood draw, right? Just like any routine physical.
Yeah, very simple. They take a small amount of the patient's blood, put it into a centrifuge, and they spin it at a massive frequency.
And that spinning action separates the blood components based purely on density.
Right.
Like the heavy red and white blood cells get pushed to the bottom of the tube.
Exactly. And what's left at the top is this layer of golden plasma that is just packed with a super concentration of platelets.
I always think of platelets as like the body's natural emergency repair crew. When you get a bad cut on your arm, the platelets rush in, they form this gap, and they trigger the healing process. So the centrifuge is basically isolating that exact repair crew and packing a massive, highly concentrated army of them into one single syringe.
That's a great way to visualize it, because what's fascinating here is their function goes far beyond just clotting blood.
Oh, really?
Oh, yeah. Once those platelets are concentrated and activated in the tissue, they release powerful signaling proteins called growth factors.
Okay, in the sources, I saw a bunch of acronyms like VEGF, TGF-beta, PDGF.
Right. But instead of getting bogged down in the medical acronyms, think about what these proteins actually do.
Okay, lean on me.
One type specifically triggers the body to build brand new blood vessels. Another type literally forces your tissue to synthesize fresh collagen. And a third type commands surrounding cells to rapidly multiply and repair localized damage.
Wow, so it's like a biological command center just telling the tissue to rebuild itself from scratch.
Exactly.
And because it's autologous, meaning it comes entirely from the patient's own body, the sources really emphasize that there's virtually no risk of an allergic reaction or rejection. Like your body automatically recognizes its own biological material.
Right. You completely bypass the risks associated with, say, implanting synthetic surgical meshes or injecting foreign bulking agents, which, by the way, used to be the only surgical alternatives when Kegels failed.
Okay, so we have a syringe full of this concentrated repair crew. But I have to pause here. Because when we talk about injecting this down there to stop urine leaks, I think most people listening are having a very visceral reaction.
Oh, I'm sure they are.
The idea of a needle going anywhere near the urethra or vaginal wall sounds horrifying, like it sounds incredibly painful.
It's completely natural to wince at that thought, but clinics are very aware of the sensitivity of the area. A medical-grade topical numbing cream is applied well beforehand, and sometimes they even use a local anesthetic block to ensure the area is totally desensitized.
Okay, so you really don't feel it.
Right. Only then does the clinician take the PRP and inject it into very specific targets, primarily the anterior vaginal wall and the periurethral area, which is just the tissue directly surrounding the urethra.
Got it. So assuming the numbing protocol does its job, this repair crew is dropped directly onto the site of the damage. And those growth factors immediately go to work. They stimulate angiogenesis, right? Which is creating fresh blood vessels to bring oxygen to the starved tissues, and they kick collagen and elastin production into overdrive.
Exactly. And over the course of a few weeks, all that newly generated collagen firms up the tissue. It literally rebuilds that sagging hammock we talked about earlier.
It restores the tension. Because before the PRP, the hammock was loose. So when a woman sneezed, The intra-abdominal pressure pushed the urethra down, but the hammock was too slack to support it and keep the tube clamped shut.
Right, so the urine just escaped.
But after the PRP, the tissue is firm, it's plump. So when she sneezes and the pressure spikes, the urethra is compressed tightly against this newly firmed connective tissue like a backboard, and it stays closed.
The mechanical support is restored natively. And the clinical data from the medical clinics in our sources shows up to a 70% reduction in leakage episodes, with some clinics reporting it as 90% effective for stress incontinence.
Okay, I have to play the skeptic for a second, because an in-house clinic reporting 90% success feels a bit like a glossy marketing brochure, you know?
Sure, it's easy to be skeptical of those numbers.
Right, because it's incredibly easy for a private business to self-report great numbers.
Mhm.
If I'm doing Kegels every single day for 12 weeks, how does a few localized injections possibly beat that kind of sustained physical effort in a strictly controlled environment?
Well, you're right. We always have to look beyond clinical claims and rely on controlled data, which is why our sources include a very recent, highly relevant prospective cohort study published in MDPI, and they set up exactly that head-to-head comparison.
Okay, so Kegels versus PRP.
Exactly. They took a group of 169 women, all formally diagnosed with stress urinary incontinence, and split them up.
Let's look at how they divided them. Because 131 women received 3 PRP injections spaced out over several months, and the other 38 women were assigned to a standard 12-week pelvic floor muscle training program, the Kegel group.
Right, but there is a crucial detail in the baseline data that makes the results of this study even more compelling. The two groups didn't start on an even playing field.
What do you mean?
At the start of the trial, the women in the PRP group actually had significantly worse symptom severity. Their quality of life scores were measurably poorer than the women in the Kegel group.
Wow. Okay, let's put that into context for the listener. When we say poor quality of life scores, and this is measured by something called the King's Health Questionnaire, we aren't just talking about a vague, I feel bad.
No, it's very specific.
These scores measure how much the incontinence literally dominates a woman's daily life. It measures the fear of leaving the house, the inability to exercise, the anxiety of coughing in a quiet room, and the impact on intimate relationships. So the PRP group was starting from a much darker, much more restricted place.
They were severely impacted, yet the findings were dramatic. The PRP group saw massive, consistent improvements almost immediately. After just one single injection, their symptom scores plummeted.
The study used the STAMI incontinence scale to measure this, right?
Yes.
And the STAMI scale actually grades incontinence based on real-world triggers. Like, grade 1 might be leaking only with heavy lifting or intense coughing, but grade 3 is leaking from just standing up or walking. And the women in the PRP group dropped so drastically on this scale that they matched the physical therapy group after just one shot.
It's incredible. And as the trial went on, the data showed the PRP group experienced consistently larger and more uniform improvements across every single metric. Now, the Kegel group absolutely saw improvement. Pelvic floor muscle training definitely does.
Right, it's not useless.
Exactly. But the data showed their improvements were much smaller on average and highly variable.
Yeah, I saw that. Some women in the Kegel group improved a lot, while others barely improved at all. It's almost like a roll of the dice depending on exactly which tissues are damaged. But the PRP group's recovery was much more predictable because it's physically rebuilding the damaged area, whereas Kegels rely entirely on the patient's daily compliance, and they only target that muscle layer.
Exactly. It really highlights the vast difference between trying to strengthen surrounding structures versus regenerating the actual damage site. However, and this is important, the medical consensus in these studies strongly suggests this doesn't have to be an either-or situation.
Oh, right. The ultimate dream team protocol is actually combining the two.
Yes.
You use the O shot to physically regenerate and firm up the damaged connective tissue, restoring the tension in the rubber band. Then you use physical therapy to strengthen the underlying muscle that supports everything. That combined approach just offers the most robust recovery possible.
It really is an incredibly comprehensive approach to pelvic health, and treating the root cause of the leaks actually led to another major discovery in the clinics.
Here is where it gets really interesting.
Yeah, because when doctors started doing these injections specifically for incontinence, the patients started coming back and reporting some very intense, very positive side effects.
Which brings us back to how this procedure originally got its marketing name, the O shot. Because you are injecting growth factors that stimulate brand new blood vessels and repair damaged nerve endings, the benefits extended far beyond just mechanical support for the bladder.
Right. Women in these studies reported a dramatic shift in their sexual wellness.
We are talking about heightened physical sensitivity, stronger and much more frequent orgasms, and a significant increase in natural vaginal lubrication.
And it goes beyond just sexual enhancement, too. For many women, it resolved intensely painful conditions. The data shows significant decreases in dyspareunia.
Which is the medical term for painful intercourse.
Exactly. And often that pain is caused by dense scarring from episiotomies or natural childbirth tears, or even the thinning of tissues that happens naturally as estrogen drops with age.
But the PRP regenerates that tissue. It breaks down the rigid scars and makes the area supple and healthy again.
It does. The sources even highlighted its success in treating lichen sclerosis, which is this chronic, intensely painful skin condition that causes severe itching and tearing of the vulva. The PRP actually reverses those tissue changes. It's literally turning back the biological clock on that specific tissue.
It really is a testament to the power of autologous cellular therapy. So for someone listening who is thinking about actually exploring this, what does the timeline look like? Like, practically speaking.
It's surprisingly fast. The entire procedure, the blood draw, the centrifuge spinning, the numbing process, and the injection, it all takes under an hour. It's just a simple outpatient visit.
Okay, but it's not an overnight fix, right?
Right, because tissue regeneration takes time. Your body has to actually build the collagen. Most patients notice initial improvements in about 3 to 4 weeks, with the regenerative process peaking at about 3-month mark.
And how long does it last?
The results usually last anywhere from 12 to 18 months, though some clinics report benefits holding strong for up to 3 years.
Wow, 3 years.
Yeah. But because the body does continue to age naturally, many women opt for an annual maintenance shot just to keep the tissue firm and healthy.
That makes sense. But there's one massive safety caveat in the sources for the recovery period that really caught my eye. Patients are strictly forbidden from taking NSAIDs, so medications like ibuprofen, Advil, or Alev, for at least a week after the procedure.
Yes, that is crucial.
And at first, I thought that was crazy, because if you just had needles injected into a highly sensitive area, popping an Advil is the very first thing you'd reach for to manage the soreness.
It sounds completely counterintuitive, right? Until you understand the biology of healing. NSAIDs are anti-inflammatory drugs, but the PRP therapy actually relies on creating a localized, controlled inflammatory response.
Okay, explain that.
That temporary inflammation is the literal alarm bell that wakes up your body's stem cells and tells them to start repairing the area.
Oh, so if you take an anti-inflammatory, you silence the alarm.
You effectively ruin the treatment because you shut down the repair process before it even begins.
Wow, so what do they do for the pain?
If a patient has discomfort, they are advised to use acetaminophen instead, like Tylenol, which handles pain without suppressing the inflammation. Clinics also advise avoiding tampons and abstaining from intercourse for about 3 days.
Just to allow the injection sites to fully close?
Exactly, to prevent infection while the tissue is vulnerable.
So let's bring all of this together. We started by asking if the O-shot can actually reduce bladder leaks after childbirth. And looking at the clinical data, the biology of connective tissue, and the head-to-head trials against traditional physical therapy. Well, the answer is a resounding yes.
The evidence is certainly there.
Right. The O-shot isn't just some cosmetic fad or a purely sexual enhancement tool. It is a scientifically backed, autologous regenerative therapy. It physically rebuilds the structural integrity of the pelvic floor, offering a highly effective, non-surgical alternative for postpartum stress incontinence.
We are definitely moving past the era of mere symptom management, and we're stepping into an era of true structural healing for women's health.
So if you or someone you know is dealing with the daily frustration of postpartum leaks, you need to know that you don't just have to live with it. You don't have to accept it as just the inevitable cost of having a baby. There is an entire frontier of regenerative medicine waiting to help you rebuild.
And, it leaves us with a pretty profound question about the future of medicine in general.
How so?
Well, if we can successfully harness the concentrated healing factors hidden inside our own blood to reverse the physical trauma of childbirth, what other inevitable signs of aging or physical decline might we conquer next? What else might simply be a matter of learning how to better redirect our body's own internal repair crew?
That is an incredible thought to leave on. The medicine is already inside us. We're just finally figuring out how to aim it. Well, thank you for joining us on this deep dive. Keep questioning the status quo, keep learning about your body, and keep exploring. And remember, sometimes fixing the most complicated problems isn't about patching things from the outside. It's about giving your body the tools to rebuild itself from the inside. We'll catch you on the next deep dive.